Excellent. All right, then we'll get started. Welcome back, everyone, and thank you for joining us today as we continue our journey to cover the 5 steps of evidence-based practice. Today, we're covering step 4. So we're looking at appraising the evidence by interpreting the study results and their significance. My name is Dr. Zoe Mycliffe, and I'm the Research Operations Manager at Northern New South Wales Local Health District. And I belong to one of the member organisations of the Rural Research Collaborative Learning Network, otherwise known as the RR-CLaN. And I'm once again joined by Dr. Alex Stevens, the Northern New South Wales Local Health District Director of Research, who will be guiding us through today's session. Before we begin, I'd just like to acknowledge the traditional custodians on the lands and waters where we work and live. We acknowledge the traditional custodians' living culture, their connection to country, and their contribution to the life of this region. We pay our respects to the ancestors and elders of the region and to all the Aboriginal people past, present and future, and to any Aboriginal people joining us here today. So we've been on a bit of a journey together so far. We've gone from asking an answerable research question in week 1 to acquiring the high quality research evidence in week 2. Last week, we had a look at appraising or assessing the believability and usefulness of that information or research articles. And we're going to just do a very brief recap on the key points that we found out from last week. So we looked at a gold standard approach versus a pragmatic approach. And we also considered the main biases at play. So when we are appraising or assessing the research that we find, the key areas of bias that we're looking for are the selection, detection, and measurement biases, and we'll have a quick look at those now. So why do we use research overall? So as health professionals, we often ask questions about our individual patients, but we know that no 2 patients are the same. And so in order to make more robust decisions, we really need to rely on information that's obtained from more than one patient in order to capture that variability in how patients present and how they respond to treatment. So this is why we use research evidence. So ideally to answer our questions, we would use evidence that's been obtained from a population of individuals who are similar to our patients. But this now takes it to the next extreme in the fact that it's not often feasible or realistic to collect information from everyone who presents like our patient. So what researchers do in order to overcome this is they take a sample of the population who's representative of that population we wish to apply the results to. Based on that sample, they use outcome measures to then collect information or data from the people who have been recruited in that sample. The researchers then summarise and analyse the results of the information that they collect. And they use those results from that sample to make inferences or apply the understandings and learnings from that sample to the wider population. And so when we're thinking about how this process can go wrong, the 2 aspects that can impact on the believability of the research that we find relate to how the sample is obtained. So last week we talked about making sure that that sample is representative of the larger population. So again, if you're collecting black sheep, that sample of black sheep is not likely going to be applicable to that larger population. You want to make sure that the sample comes from within the population you wish to apply the results to. And the second source of bias comes from the outcome measures that the researchers use and the procedures or how they go about collecting that information from the participants. So critical appraisal is the systematically examining research to judge its believability or validity and the usefulness of the article. And we found out that last week there's 2 approaches that you can do this. You can use a gold standard approach using checklists or critical appraisal checklists, depending on the study design that you're using. And while these are the gold standard, they're reproducible. They are quite detailed, and while they can give you a good understanding and learning opportunity to understand the key areas of where the process can go wrong, they are a little bit time consuming. And as a busy clinician, we encourage you to take at least a pragmatic approach every time you pick up a research article. And using a pragmatic approach, what we're encouraging you to do is use the skill of targeted reading. So you're not just picking up every research article and reading it cover to cover. Instead, what you're doing the first time you're looking at the article is you're doing a quick skim read, and you're pulling out the elements that will enable you to assess the believability of that article before you read that article in full. And only if you think that the article is believable or valid, do you then go on to have a look at whether the results are useful. So in order to assess the believability of the research that you find, we use the framework Align, Design and Conduct. And again, we're encouraging you to use this skill of targeted reading in order to assess that believability. So again, you're not reading the article from cover to cover. If you're interested in learning more about this framework, we encourage you to go back to the RR-CLaN YouTube channel and have a look at last week's presentation on how to apply this framework in more detail to the research that you find. Only if the results are believable do you then go on to assess the usefulness of those results to your patient and to your setting. And so in doing so, what you're going to be looking at is looking at the applicability of those findings to your patient, to your setting, and also considering the results in terms of their importance and whether or not they meet some sort of threshold that you think is important for your patient or that meets your patient's level of importance. So this brings us to step 4, or apply. And this week we're going to have a look at how to interpret the results and its significance in terms of both statistical and clinical significance. Very briefly, you've been on this journey with us for a little while now. So there is a workbook that coincides along with this seminar series, and it's a resource for you to keep. Take notes, there's the group activities, and importantly, there's templates there to enable you to tackle your own clinical questions in a guided approach. We do give the warning that there's a lot of new concepts and content covered in the seminar series, and by the end of the 5 weeks, you might not feel completely comfortable with everything that's been covered, but we do encourage you to return to this workbook to recap some of the skills and information that you will have heard. We are recording this session, so please keep your microphones on mute throughout the session. And if you don't want to appear on the recording, please turn your cameras off. We will be taking questions. If you have any questions during the session, please feel free to pop these into the chat and Alex will look to answer them at his soonest convenience. Otherwise, at the end of the session, we will open the floor up to take some live questions if you've got them. That's it from me. I'm going to pass it over to Alex now, who's going to go through today's session and looking at how we interpret the findings and their significance. Thank you, Alex.
Thank you very much, Zoe. So step 1, hopefully I've shared my screen correctly. Does that come up?
You have, Alex. Thanks.
Okay, awesome. So thank you very much, Zoe. So as Zoe said, you've made it to step 4. The step 4's around apply. So I won't sugarcoat it. This session is a little bit like a statistics lecture. So probably will be the least comfortable out of the entire series if you attend all of it. But hopefully what we'll be able to communicate today and go through will equip you with the skills and confidence that you can repeatedly and confidently go into the literature and be able to make sense of the results presented in the articles or the studies. So today's session really is about interpreting the results arising from statistical analyses and their significance. So don't get too uncomfortable, although we're going to be talking about statistics and statistics concepts. What we're going to cover in the session today is nowhere near as difficult as actually doing the statistics, interpreting it, and hopefully if we do this properly, you'll find is a lot easier, and there's a few tricks you can use to do this repeatedly and easily. So by the end of the session, you'll be able to identify the 2 main ways to compare data from studies of treatment effectiveness, be able to interpret something called the null value, which is the point or the value which represents no difference between study groups in whatever outcome is being used in that particular study. And also interpret something called the 95% confidence interval relative to both statistical significance and clinical significance. So one of the main take-home messages from today will be something called this confidence interval. I'll talk about it a lot, and it's probably the critical feature. If you remember anything from it, it's really how to interpret that. So why are we up to step 4? Well, last week we talked a little bit about critical appraisal. So we did a very good job in guiding us through the pragmatic approach to appraising articles, making sure that the results are believable and useful. And in step 4 here, we're going to focus in more on what are the results and can they apply to your patient populations or your clients. And we're largely going to do this through the lens of treatment effectiveness studies. Now, going back a little bit, you may recall that the best or acknowledged study design that generates the highest quality evidence for treatment effectiveness is the trusty randomized controlled trial. I've got a little figure here which depicts what it is. And we're going to start essentially by looking through the lens of understanding those trial results. So we do a randomized controlled trial. The aim might be to determine the effectiveness of one treatment compared to the other. This is how the trial works. We'll sample from a population, randomly allocate them to at least 2 study groups. Some patients or participants get allocated to treatment group A, others to treatment group B. Over time, we follow them and gather some information of their outcomes. And what we want to do is get an understanding of whether there are any differences in the outcome between those 2 treatment groups. And it's as easy as comparing the means of the outcomes between those 2 treatment groups. So that gives us the how. So we'll go through a little bit of an example here. And this is a hypothetical example. It's assessing the effectiveness of a drug which looks to reduce blood pressure in hypertensive patients. So going through our trial design again, we sample from the population, we randomly allocate them to either treatment A or treatment B, follow them through time, obtain information on their blood pressure, and essentially to determine whether there are any differences between the groups, we'll compare mean blood pressure between the groups, and this will give us an estimated effect of whatever this treatment we're interested in. So for example, we might be looking to see whether treatment A reduces blood pressure compared to treatment B, and we would just essentially just calculate the difference in blood pressure between the 2 groups. So this is kind of how you depict it. We would say that difference in blood pressure is equal to the estimated effect, and mathematically it looks like that. So it's the mean blood pressure in group A minus the mean blood pressure in group B. So this was a hypothetical example for quantitative data. So we're going to go on a little bit of a tangent now and focus a little bit on the types of data. This is not absolutely critical, but it helps to frame what we're going to go through in the rest of the session today. So we're going to speak about 2 main types of data and how to interpret the results of statistical analyses using those types of data. So there's 2 main types. You'll probably have heard of them. There's quantitative data and then there's qualitative data. If we focus in on the quantitative data, there's multiple subtypes for those ones. There's discrete scale and then there's a continuous scale. Discrete scale variables data can take on only specific values within that scale. And a good example is shoe size. For continuous variables, data can take on any value within the scale. And that's got 2 main subtypes, which is interval scale data or ratio scale data. And the distinction between those 2 is how they deal with 0. So interval scale data does not have a true 0. Really good example is temperature in degrees Celsius. And the ratio scale data does, for example, height, heart rate, blood pressure. The other main type of data is called qualitative data. And I think it's probably easier to refer it as categorical data. That's got 2 main subtypes, which is nominal and ordinal. As the name suggests, nominal actually deals with purely the qualitative characteristics of the variable. There's no natural or rank order to nominal data. Good examples there are eye color or sex. Ordinal data does have a structure or rank order to them, and education levels is an example there. So we've got two main types of data, and really there's only two main ways to compare data from studies of treatments effectiveness, and this is what we're going to learn in today's session. For quantitative data, how we determine the differences or measures of treatment effect is by calculating differences, and we calculate the difference between the two groups, and we focus on the difference in means. Ratio are used to assess the effects of categorical data. This is a little less intuitive, but the ratios essentially express the levels of the outcome in a study group, say study group A, to the levels of the outcome in another study group, say study group B. So we'll start off with quantitative data, work through a few examples, and then we'll finish off the seminar today by going through examples of qualitative data. So as I just mentioned, the estimated effects or treatment effects for quantitative data are expressed or calculated as differences. So we're going to work through a hypothetical example. There'll be some polls that we're going to use throughout today's session, and Zoe will hit me in check there and make sure that we launch them at the right time. So in our hypothetical example here, we've got again two treatment groups. The outcome measure here is the pain scale. And so hypothetically for treatment group A, somebody or people in that group are assigned a particular drug, say the red pill, and we've got some pain scores from them. So individual 1 has a pain score of 5, individual 2, 7, and so forth. So 6, 3, 2, 1. We can calculate the mean pain score in that group, which is equal to 24/6. And we see that the mean pain score is 4. We can do exactly the same thing in the blue pill group. So we've got the data from the individuals in that group. There's 6, 8, 4, 4, 1, 1. We calculate the mean. Because it's a quantitative variable, the estimated treatment effect is given by the difference, and essentially it's by calculating the difference between the two groups in terms of the means. So I know there's a poll now, Zoe, which has come up or will come up. Hopefully that poll question comes up, and the poll question is, for this data, what number would indicate to you that there is no difference between these two treatment groups? Take a little bit of time to answer that question. I've got the responses coming through now, and most of you have picked 0, which is good. A few of you have picked 1, but hopefully we'll reinforce the concepts. But for quantitative data, the value that indicates that there is no difference between treatment groups is in fact 0, because the treatment effect is estimated by calculating the difference. So well done, everyone. We'll keep going through these concepts and hopefully be able to reinforce them. So if we continue working through this example, we want to calculate the treatment effect, and that's given by the differences in the mean between the two treatment groups. And it's fairly easy this time for this example. We see that both groups have a pain score or mean pain score of 4. 4 minus 4 is 0. So just to reinforce the learning here, if it's a quantitative variable, the estimated treatment effect is calculated as the difference and is expressed as the mean outcome variable in treatment A minus the mean outcome variable in treatment group B, which is equal to the difference in treatment groups. It's important to remember that the point of no difference, which indicates that there are no differences between the means of the treatment study groups, is 0. So we'll continue working through some examples to try and reinforce some of the learning. And this one's again our hypothetical example. We're continuing to explore this magic drug that reduces blood pressure in hypertensive patients. We've got our two treatment groups again, treatment group A and treatment group B. We can say hypothetically treatment group A was just like the standard routine care treatment, and treatment group B received this new wonder drug. What statisticians like to do at the end of a study is they like to do some descriptive analysis. One way is to just calculate the mean of the outcome in each of the treatment groups, and we can do the same here. So we see the mean blood pressure in treatment group A was 134 millimeters mercury, and in treatment group B, 111. But what we're really interested in is calculating the difference. So we can see here there is a difference, and we can precisely calculate that difference. In fact, it's around 23 millimeters mercury lower in treatment group B compared to A. So we can leverage from the mathematical machinery of statistics to actually calculate a measure of precision in our estimated difference there. And we commonly express that in the form of something called a confidence interval, which we'll talk a little bit more about very, very soon. We've flipped it on the side here in terms of assisting with the interpretability of what we're going through. But essentially, we've got an estimate of the mean difference between the two treatment groups of minus 23 millimeters mercury, and then we've got the lower bound and the upper bound of our 95% confidence limit. So let's talk a little bit about these point estimates and the 95% confidence interval, because that's really key to understanding how to use these effectively. The confidence interval, or the 95% confidence interval, actually provides a range for the plausible value of the true population parameter. And it's interpreted in this particular way. So if there was a long series of identical repeat experiments, an investigator were to do the same experiment over and over and over again, many, many, many times, what they will find is that 95% of 95% constructed confidence intervals will contain the true population parameter. Bearing in mind that for this hypothetical example, the true population parameter is the difference in mean blood pressure between the two treatment groups. So based on that definition, for any 95% confidence interval we construct, we probably like our chances that true population parameters fall somewhere within there. What we don't know is exactly where that population parameter sits. It could be right at the low end here, it could be in the middle, which we define the point estimate, or it could sit right at the top. We'll talk a little bit more about the confidence interval and its useful relationship with the p-value. Once we go through this, you'll understand why the confidence interval is probably the only thing that you really need to understand and be able to interpret, because everything else connects to it. And there is a handy relationship between a confidence interval and the p-value when we compare it or overlay it with the points of no difference. So here we're talking about quantitative variable, remembering that the point of no difference is where there are no differences between the group means. So we're focused on 0. In this graphical example here, we've got two estimated mean differences and their associated 95% confidence intervals, A and B. If we focus on A first, we see that its confidence interval overlaps with the null value or the point of no difference. And essentially, every time this occurs, it will be a non-statistically significant result, meaning that the p-value will exceed typically the common threshold of 0.05. So that's just a rule, a handy rule to remember. If we look at our second estimated mean difference, B here, and its associated 95% confidence interval, we have intentionally shifted it to the right such that it doesn't encompass the point of no difference. And I would immediately see that and say, look, that difference there is significantly greater than 0 because it doesn't encompass the point of no difference. Now we can build on that concept and use exactly the same approach to start interpreting points that we would judge to be clinically relevant. So here we've just extended what we looked at previously. We've added a third estimated mean difference and associated 95% confidence interval, and we've also overlaid a hypothetical clinical important difference. These clinical important differences are usually derived from domain knowledge or prior studies or some subject matter expertise. So they're not always out there, but it requires a little bit of searching to be able to figure what they are for various types of outcomes. So we can disregard A. We know that's not statistically significant and won't be clinically relevant. B, on the other hand, we knew it was statistically significant, that estimated mean difference. It didn't include the null value. We see that the 95% confidence interval does overlap with the point of clinical importance. So I would tend to interpret that as having the potential to be clinically relevant, but you would require further testing, a larger sample size to definitively assess that. As it stands, there is insufficient information based on the confidence interval to say that the estimated mean difference there is clinically irrelevant. We navigate to our third estimated mean difference, and again, we've done this intentionally. We've shifted that one even further to the right. We know it's statistically significant. It doesn't include the null value of the confidence interval. And we also know it exceeds the threshold of clinical relevance because the 95% confidence interval, which provides the plausible range of values for the true population parameter, exceeds that. So even if the true population parameter is at the lower limit of the confidence interval, it still exceeds the point that we would say is clinically relevant. So that's a statistically significant finding and also a clinically relevant finding. So we're going to go back to our hypothetical example and try to put this into practice. So remembering, we've estimated a reduction in blood pressure in the treatment B group relative to A of 23 millimeters mercury. We've got our 95% confidence interval. I think Zoe's about to launch a poll. We're going to answer the question as to whether that is a statistically significant result. It's a very good start. The overwhelming majority have said, yes, it's a statistically significant result, which is the correct answer. But just to reinforce the learning, it is a statistically significant result because that 95% confidence interval here does not include or overlap the value of no difference. Right, so well done. Good job, guys. So we're going to launch another poll now, I think. And this time we're going to interpret it in relation to whether that result is clinically relevant. Well done, everyone. I think that most of you are getting it. And it is also a clinically relevant result. And this one's a little trickier because it's displayed in the opposite to the examples we did previously. But we've got our point estimate, a 95% confidence interval. We know the drug reduces blood pressure compared to treatment group B. We know it could be as low as, say, -30 or roughly -16 or 17 or something like that. We've put in a hypothetical clinically important difference of a reduction in 15. The 95% confidence interval does not include that clinically important difference. It actually exceeds it in a negative direction. So it reduces blood pressure beyond the clinically relevant difference. So it's also clinically significant. So we're going to continue going through a few more examples, or at least a couple more examples for the quantitative outcome variables. This time we're going to go back to our trusty parachute article, so year et al. And we're going to have a look at one of the outcome measures they used, which was the short form health survey score. Now in the results, they presented the mean of the short form health survey for the parachute group, the control group. You can see it's 43.9 in the parachute group, 44 in the control group. So it's very similar. The difference, you guys can manually calculate it, but it's 0.1. And they've also calculated the confidence interval of the estimated difference ranging from -2 to 2.2. So we know it's a continuous measure. And we're going to launch one final poll in this section, which is going to ask, what number do you think would indicate there is no difference between the treatment groups? Is it a 0, a 1, Or you can answer, I'm not sure. And then there's a second part to this question, which seems to have worked fine. Based on the constructed 95% confidence interval, remembering whether it incorporates the null value or not, do you think this finding is statistically significant? So for that first part there, what number would indicate to you that there is no difference? Most of you have correctly indicated that the point of no difference is 0. And then we'll work through the second part. Is this finding statistically significant? Again, the majority have said no, a few of you have said yes, but the result is not statistically significant. And the reason being is the 95% confidence interval includes the point of no difference. It's depicted graphically here. And every time that occurs, it's a non-statistically significant result. And we can do our little verification exercise by having a look at the p-value. And that p-value there is well above what will be the typical threshold used of 0.05. So, covered that. Got one last example. Everyone's actually doing really, really well in terms of grasping some of these concepts, which is really promising. So we've got a second published article here, which is on the effect of graded sensory motor retraining on pain intensity in patients with chronic low back pain. And these are some of the findings from a randomized control trial. So if we have a look at some of the content of the abstract, the main outcome variable, or the primary outcome, was pain intensity at 8 weeks. And this was measured on an 11-point numerical rating scale. So again, we're dealing with a quantitative outcome variable. They have gone to the lengths of mentioning what the minimum clinically important difference is, which is 1 point in that scale. We navigate to the results. We can have a look at what the estimated effect of the intervention is. And here they noted that the estimated between group mean difference at 18 weeks was 1 point, favouring the intervention group. So what essentially would it mean is the pain score in those intervention group on average was 1 point lower than the control group or the comparator arm. Of course, I'm more interested in having a look at the confidence interval that ranges from -1.5 to -0.4. And I know based on that, it doesn't include the value of no difference, 0, and therefore the finding is statistically significant. So just to reinforce, that confidence interval provides a plausible range for the true population parameter. We don't know where it is in this range. It could be as low as that, could be as high as there, but ultimately either the lower bound here or the upper bound is certainly exceeds the point of no difference, which is 0. So this is also a statistically significant result. And we can do a little exercise here to verify by having a look at the p-value. So I'll move on. In the same published example, they had a longitudinal follow-up. They measured pain again at 26 weeks and 52 weeks. We can do the same thing. We can have a look at the estimated treatment effect. So we know at 18 weeks, it was a reduction in pain score of 1. At 26 weeks, it's a little reduced. It's still a reduction in pain, but it's 0.7. Confidence interval ranges from -1.2 to -0.1. It's still a statistically significant result. Then we have a look at week 52. The estimated treatment effect, again, is a bit more attenuated. This time, only a reduction in pain score of 0.5. The confidence interval this time ranges from -1.1 all the way to +0.1, because we know now that it includes the point of no difference of 0. This will actually be a non-statistically significant result. So you've done very well. We've covered some key concepts. It might be a little bit difficult to grasp, but please continue going through as much as you can to try and understand these core concepts. Will make going through the results of articles a whole lot easier. So we've looked at quantitative data. For the rest of the session now, we're going to focus on qualitative data, because some of the outcome variables in studies can be categorical in nature. I guess I'll start off by saying this is less intuitive, I guess, in a way, but hopefully we'll be able to guide you through some of the key concepts and just revisit them as many times as you want. Estimated treatment effects for categorical data is expressed as ratios. I said it before, essentially it's the form of levels of the outcome in one study group over the levels of the outcome in another study group. So we'll start off with an example again. We're considering ratios. In our hypothetical example, we've got the red pill and the blue pill again. Our outcome variable this time is at the end of the study, whether participants have passed or not. Are they dead or alive? And so in the red pill group, we see at the end of the study, we've got 2 unfortunate people which have passed. So the risk of death in group A is 2 out of 10. So the proportion which have died is 0.2. You can do exactly the same thing in the blue group. Also 2 people unfortunately died. The risk of death, again, 2 over 10, and the proportion which has died is 0.2. So to get a sense of the effect of a particular drug, let's say the red one, on the risk of death compared to the comparator, say the blue, you just do a ratio of the proportion which have died. This gives us a risk ratio of death, which is essentially the risk of death in group A divided by the risk of death in group 2. Because we know that the proportion that have died is identical in both groups, it's going to be 0.2 over 0.2. And most of you have probably already calculated that that gives us a result of 1. So this reinforces or just highlights when the outcome variable or the levels of the outcome variable are the same in the 2 study groups or categorical variable, whatever we're looking at in terms of the outcome, be 1. So the point of no difference is 1. So that's important to keep in mind. So estimated effects are typically expressed as ratios for categorical data. Examples of these ratios could be risk ratios, odds ratios, rate ratios, hazard ratios. Invariably, some of you probably have heard some of these terms used before. And essentially what you're looking at is if treatment A is as effective as treatment B, this will give you the point of no difference and the ratio of 1. So we're going to go through another hypothetical example. We're sticking with our blood pressure example here, except we're looking at a descriptive analysis, which is assessing the association between socioeconomic status and hypertension, defined as blood pressure equal to or greater than 140 millimeters mercury. So like many statisticians or analysts, we like plotting the data. So we can have a look at the proportion hypertensive across our 3 socioeconomic status groups. We've got average, average and disadvantage. See the proportion hypertensive in the advantage group is 0.09, so it's very low. Slightly high in the average group, so just over a quarter are hypertensive, and then again, slightly high in the disadvantaged group. Now, the way the analysis of categorical data works is we typically choose one of the study groups to be the reference level. And here I've gone with average. So this is going to be the group that we compare all the levels to in a relative sense. So we can immediately see just by doing a visual examination that the levels of hypertension are lower in the advantage group compared to average and are slightly higher in the disadvantaged group compared to average. And this is exactly how the statistical machinery will spit out the estimated effects. So if we move on and have a look hypothetically at what that might look like. A statistical analysis, for example, a logistic regression, might spit out something called an odds ratio, which is essentially looking at the ratio of the odds of the outcome between 2 study groups. Remembering that our reference level this time is the levels of hypertension in the average socioeconomic status group. And if we have a look at the odds ratio for the advantage and odds ratio in the disadvantage, it completely aligns with the thought experiment we did before. We know that the levels of the outcome are lower in the advantage group and slightly high in the disadvantaged group. Now, just like our quantitative data analysis example, the mathematical machinery of the statistics used for the analysis of categorical data can also generate measures of precision in our estimates. And they're also 95% confidence intervals. They look a little odd because the estimated effect or the point estimate doesn't quite sit in the middle, but ignore that for the moment. How you interpret these 95% confidence intervals is exactly the same. Now, the critical ingredients are knowing what is the point of no difference. And we know for categorical data, it's a ratio of 1. And then it's about figuring out whether the 95% confidence interval overlaps with that point of no difference or not. So based on that, if we have a look and try to interpret the confidence interval for the advantage group, it ranges from the upper limit here to a lower limit there. It doesn't include or encompass the point of no difference. So we would say or conclude that the proportion hypertensive in the advantage group is significantly lower than the proportion hypertensive in the average group. We'll apply that exact same lens to our disadvantage group. We knew the levels were slightly higher, but we don't know whether it's statistically significantly higher or not. We look at our confidence interval. It's very wide for this particular example, and it does encompass the point of no difference. So while the relative levels are slightly higher in terms of those hypertensive in the disadvantaged group, it's not statistically significant. So again, the exact same link between the 95% confidence interval and the p-value exists for categorical data. Again, here we've got estimated effects, 3 hypothetical ones, A, B, and C. If we focus on A, the odds ratio is 2.5 of the 95% confidence interval. We know the point of no difference is 1. That certainly exceeds 1, so that would be a statistically significant result. B, on the other hand, again, has a slightly higher odds of whatever the outcome is, but the confidence interval overlaps the point of no difference, so this is a non-statistically significant result. C is an interesting case because it's the exact opposite of A. It has a lower odds relative to the reference group, or whatever the outcome is. The 95% confidence interval does not overlap 1, so that would be also a statistically significant reduction in whatever the outcome is. So to finish off, we're going to go through a few examples to try and reinforce the concept we've spoken about for the analysis of categorical data. This is a published study which is on exercise for preventing falls in older community dwelling individuals. And this image here presents a truncated forest plot. And a forest plot essentially is a specific type of technique, I guess, to present the results. And it presents the results of individual studies which were incorporated in the systematic review of this particular article. So these here are individual studies which explored this exact concept. And we can have a look at what the results for the individual studies were. And these are rate ratios. And sorry, Zoe, was there supposed to be a poll now? Awesome. So continuing with our concept of categorical data, when we're interpreting these individual estimated rate ratios, what number would indicate to you that there were no differences between treatment groups? Is it 0, 1? I'm not sure, don't have enough information to tell. People done very, very well. So the bulk of you said 1, which is the correct answer. Some of you said 0, but we'll continue reinforcing the concepts. So for categorical data, remembering that the estimated effects are presented as ratios, and the point of no difference is when the outcomes are the same. So the ratio would actually be 1. So we could go through and explore each of these individual results, which is not the most interesting thing in a systematic review. Probably the most interesting thing is when the results are combined, and there's statistical methods to combine the results across all these different studies and present them as one final combined estimate, which is represented by the diamond here. And so overall, the effect of exercise for preventing falls is effective. The rates of falls in the exercise group is about 0.8 that of the falls experienced by the control arm or the comparator arm. And we have a look at the confidence interval ranges from 0.71 to 0.83. It doesn't incorporate the value of no difference, so we know that would be a statistically significant finding. Second published article here, this is the association between statins and adverse events in primary prevention of cardiovascular disease. This was also a systematic review. The table here is slightly different to the truncated forest plot in that it's having a look at a variety of different outcome variables, and these are the combined estimates obtained through meta-analyses of these outcomes. So they're already combined estimates. The outcome variable here is expressed in terms of the odds. And so we're looking at the odds ratio, essentially. What are the odds of the outcome in the treatment arm versus the odds in the comparator arm? So we could systematically work through all these results, and we pick the first one, for example, muscle symptoms with statins does result in a slightly increased odds of having them if you're on statins. You look at the confidence interval and it ranges from 1.01 to 1.13. So it's a very small overall effect. It's still significantly different, but whether it's clinically relevant or not requires a little bit more interpretation, and that's a little harder to do with categorical data. What's another one that is statistical? Liver dysfunction. So for those which are on statin, the odds of having liver dysfunction is 1.33. So their odds are increased compared to those which aren't on statins. Confidence interval ranges from 1.12 to 1.58. That certainly doesn't include the point of no difference of 1. So people, unfortunately, which are on statins experience higher likelihood of liver dysfunction. They've got some key outcomes here, which very sensibly they've explored. Obviously, myocardial infarctions are really good to have a look at. It's probably the primary purpose of being on statins. And of course, good news story, individuals which are on statins experience a much lower likelihood of experiencing myocardial infarction. The odds ratio is 0.72. Confidence interval ranges from 0.66 to 0.78. So statins certainly do have a protective effect for heart attacks, and it's significantly so because it doesn't incorporate or include the point of no difference within the confidence interval. So we're going to play a little game now of zeros and ones. We're just going to work through a little bit of an exercise to put the finishing touches on what we've covered today. And so, all right, the first one is we're going to determine, based on a variety of outcome measures, whether it's quantitative or qualitative variable, and then based on that, what the point of no difference was. So this is not a poll, it's just an exercise we can do all together. So for pain scale, we know it ranges from 0 to 1. Might be sort of a discrete type of variable, but it's a quantitative variable. So we know it's continuous. And for quantitative or continuous variables, we know the point of no difference is 0. The next one is dead or alive. This is a binary variable. It's a categorical variable. And we know for the categorical variables, the point of no difference is 1, because we explore them as ratios. Age and years, surely this is screening continuous. That's correct. And the point of no difference is 0. Blood pressure, which featured in some of our examples today, well, we know that's continuous. So the point of no difference is 0. And then we've got another yes or no. Previous fall gets it to categorical variable, and the point of no difference is 1. So we're nearly done. I know this has probably been a heavy session. We're going to go through one final example. And this is a good one because it contains a mixture of outcome variables that are quantitative and qualitative. So this particular study here is the effectiveness of a multifaceted intervention to improve emergency department care of low back pain. This was a step wedge cluster randomized control trial. The primary outcome was the proportion of low back pain presentations receiving lumbar imaging, but they had a number of other useful secondary outcome variables, which we'll explore in the results. But we focus on the primary outcome variable, which was reducing lumbar imaging. This was essentially whether you got imaging or not. So it was a categorical variable. So we're looking for a ratio. And here they've expressed it as the odds essentially of receiving lumbar imaging, and the estimated effect is represented as an odds ratio. So we can see there that the intervention did slightly reduce the odds of receiving lumbar imaging. However, the confidence interval was quite wide. It ranged from roughly 0.5 to 1.25. Encompasses our point of no difference of 1, so that's not a statistically significant finding. However, when they looked at opioid prescription for management of pain, they did find that the intervention did significantly reduce the use of opioids. Here, the odds ratio was 0.57. The 95% confidence interval ranged from 0.38 to 0.85, so it doesn't include a null value of 1, and the p-value is significant. They also explored quantitative outcome variables. One was the clinician's beliefs, and the intervention did actually improve clinicians' beliefs about back pain care. Whatever scale this was an increase in 2.85, and the confidence interval ranged from 1.85 to 3.85. So we know for quantitative data, the point of no difference we're looking for is 0. The confidence interval does not include that. It exceeds it. It's a statistically significant result. And the knowledge about back pain care was very similar. It had increase in that scale of 0.48, ranging from 0.13 to 0.83. Again, not including our point of no difference of 0. It was a statistically significant result. So just a recap of the session, there are only two ways, or two main ways, I guess, of assessing intervention effects. For quantitative data, we're looking at mean differences and the point of no difference being 0. For qualitative categorical outcome variables, you're basically looking for ratios and the point of no difference is 1. Results will typically be reported as point estimates and associated 95% confidence interval, remembering this is probably the most important component of a statistical result, that being the 95% confidence. In terms of statistical significance, if the confidence interval doesn't include or overlap with the point of no difference, it will be a statistically significant result. Clinical significance needs to be considered when interpreting and applying the evidence. It's a little easier to do that for quantitative outcome variables, a little less intuitive for categorical variables, but it's still something important to bear in mind. So that is the end of the session. I'm going to put it back to Zoe, who will talk a little bit about some of the homework. If you're going to attend our next session, a little bit of homework you can do in preparation for that session.
Brilliant. Thanks, Alex. And so pleased that a lot of people got these concepts today. It's fantastic to see that you followed along, and hopefully you've got some tips and tricks to interpreting research moving forward. So as Alex said, next week we come to the end of our evidence-based practice journey. And in preparation for next week, we're sort of bringing it all together. So we'd appreciate if you take a few minutes, it might be on your drive home or just even before the session, that's fine, just to ponder these three questions. They are on page 46 of your workbook. You might like to jot some ideas down about what you've learnt over the previous 4 weeks, and how you might think about applying them to your clinical workload and everyday life. So next week we've got Associate Professor Chris Williams presenting to us about, again, ways that we can become better or more evidence informed, so that we're evidence-based practice professionals. If you haven't registered, please do. We are keeping everyone in the loop of the sessions, so you will receive notification of next week's session. That brings today's session to a close. we're nearing the end of our journey, and thanks so much for everyone for coming along to this week's session. Look
So
forward
thank
to
you,
seeing you
Zoe.
next week.
Yeah, we do look forward to seeing you next week. I have unmuted anyone. I've unmuted people's microphone in case anyone's got a burning question, but I think probably you're burning to leave. But you've done very well. I think we ran this last year, and this was by far, the most difficult session to attend. But hopefully, we've been able to describe a few handy approaches for you to use when being able to interpret the results presented in articles.
There's lots of thumbs up, Alex, and lots of clapping. So I think you nailed it this year.
Fantastic. Sounds good. All right. Thank you everyone for joining, and hopefully we'll see you for next week's session to close it out. Enjoy the rest of your afternoons, and hopefully we'll see you next time. Bye-bye.